Okay, now that we have understood the various insulins that are available and the various insulin regimens that we know, we will just move on to see some case-based discussion on how to use these insulins in a real-time patient. So we'll just discuss about the principles of insulinization that we will go through in the next 2 sessions. So here comes Mr. A, 43-year-old on routine investigation. His blood sugar fasting is about 255 and postprandial is about 450 milligram per deciliter. So the individual is 43-year-old and he doesn't have any symptoms. Just he went through a mastocyl checkup, but his sugars are very much elevated. So what will we do? So we will be discussing on OHA based regimen. Can we give OHAs or is there any role for using insulin in this patient? That is the most important question that strikes us. So you may be asking like, why should I start the patient on insulin? So his blood sugar fasting PP is, though it is high, is not in a ketotic state. We saw about the indication of insulin. So is there something like we need to do to counsel this patient to start early? Or is there any advantage of starting the patient on insulin in this scenario? So this is something like which strikes us. There is very, very good evidence to show that people who are initially diagnosed with diabetic for the first time, when you start them on insulin, their response, their glycemic response over a period of time is very, very good. Especially when we go through this article which got published in Lancet, this study is from China, where they have recruited people with between 25 and 70 years and their HbA1c was varying between 7 and 16.7. What they have did in this study is they were able to take people like what we have seen in the case. So about 1/3 of the people were allocated to OHA groups. So OHAs also work in this patient. There are no reasons why OHA should not be used in this patient. It will lead to good control. There is no doubt about that. But what they have done is, it is not just 1/3 of the people who are allocated to oral hypoglycemic agents. Another 1/3 of the people were allocated to multiple doses of insulin. So they were put on either premix insulin or basal insulin or basal plus or basal bolus. They were put on multiple dose insulin in another 1/3 of the patients. And another 1/3 of the patients were put on the best therapies available, that they were on insulin pumps. So which was trying to control on hourly basis the glycemic excursion which was happening. So they were put on the best therapy which is possible. And they were trying to bring down the blood sugar of these people at a very short time. And once they have achieved the glycemic control, what they have did was, they tried to maintain this regimen. So whether they are on OHAs, on insulin or on insulin pump, so they were trying to maintain these regimens for another 2 weeks. And after 2 weeks, they abruptly stopped the treatment. So nothing was do over that stage. So after they were achieved the euglycemia, maintained for 2 weeks and stopped the regimen completely. What was surprising was the people who were on insulin. So after 1 year, people who were on insulin. So as you see over here, they were remitting at the end of 1 year. So they didn't have so much amount of people continue to secrete insulin even after 1 year. Compared, as you see over here, in oral hypoglycemic agents also it is achievable. But the achievement which was happening with the insulin, whether it is on pump or the multiple dose injection, people who have started insulin on diagnosis, they were remitting after 1 year. They didn't become diabetic after 1 year. They were all doing well at the end of 1 year. This is something which is amazing. Like after 2 weeks of injection or 3 weeks of injections, the people went for remission and they continue to be in the remitted state after 1 year, which is amazing. Like why we should encourage people to go on insulin when they report to us for the first time, when they are diagnosed as diabetic for the first time. So this is what the data shows. But why should insulin help in these people? So why the OHAs were not helping so much as the insulin was helping?